come over here, and my good friend, colleague, and long-term associate for nearly 30 years, Dr. Keshava, please. He has a task cut out for him. He just wants to kind of list out what are the principles on which he decides to offer TAVR, I guess, for his patients when he diagnosed one. Thank you so much.
Thank you, sir. Respected Dr. Nagta Desai and Dr. Koregal, thank you. I'm just talking on principle of selecting patient. No slide or TAVR is complete without this person. Dr. Alan Kleber, April 16, 2002, he did a TAVR on a patient who was unfit for surgery. So that was the first indication. So severe symptomatic aortic stenosis carries poor prognosis, but we do have a high risk population, elderly patients with following comorbidities, severe LV, systolic dysfunction, CVD, CAD, PVD, and CKD, chronic respiratory infection. This is a slide for aortic stenosis. When it crosses, echo shows a gradient of, mean gradient of more than 40. Aortic valve replacement is the indication. And asymptomatic patient, if you have a ejection fraction low, or if you have a gradient more than 60, is a low surgical risk, but still aortic valve replacement is a class 2A indication. And if exercise or treadmill test is abnormal, or every year the gradient keeps on increasing by 0.3, then you have aortic valve replacement. So what will happen if the gradient is between, mean is 30 to 39, symptomatic, will go to aortic valve replacement, class 2A, and these are all the indications. So most important word in TAVR is a heart team approach. You should have a cardiologist, cardiac surgeons, anesthetists, everybody, and it should be done in places where cardiac surgery is on site. And heart team approach with the surgeon definitely saying the risk of surgery for AVR is definitely higher. It's a class 1B indication. And the most important word is TAVR should be considered in high risk patient with severe symptomatic AS who may still be suitable for surgery, but whom TAVI is favored by the heart team based on individual risk profile and anatomic suitability. So in simple, if you have a low surgical risk patient, class 1, AVR, surgical AVR is the indication. Intermediate risk, both AVR is a class 1 indication, TAVR is a class 2A indication. High surgical risk, TAVR becomes class 1 indication. Prohibitively surgical risk is class 1. What does it mean is, if you have a prohibitively high risk patient, TAVR is the indication. Low risk patient, AVR is a surgical AVR still is the class 1 indication. So how do you choose? If you see here, favors SAVR, favors TAVR. If you have a younger patient, SAVR is better. SAVR stands for surgical AVR. Bicuspid aortic valve has moved from SAVR into TAVR also. Bicuspid aortic valve is not a contraindication for TAVR. Multivessel CAD, low coronary ostium, concomitant significant valvulopathy, unfavorable femoral access and other access, surgical AVR is better. Older patient, redo surgery, frailty, high surgical risk, and a porcelain aorta, favorable femoral access, TAVR is preferred. We'll, this is in detail about all the indications. We'll just, the contraindication. Absolute absence of heart team and no cardiac surgery in sight may be absolute contraindication, but nowadays even that place, even TAVR is done in places where there is no cardiac surgery on site. And if the estimated life expectancy is 1 year, less than 1 year, if you have a 90-year-old patient, comorbidity is not going to survive more than 1 year, TAVR should not be performed. And anatomical factors like annulus too small or too big, 18 mm versus now it has gone up to 32 mm. If there is a thrombus in the LV, active endocarditis, risk of coronary ostial obstruction, and mobile plaques in the aorta, or even subclavian approach, carotid approach is not possible, then TAVR is contraindicated. Bicuspid is aortic valve is a relative contraindication, untreated coronary artery disease. So you can do angioplasty along with TAVR, hemodynamic instability, and EF less than 20. These are all relative contraindications. So low operative risk. When the surgeon sees the patient, he will say, is a low operative risk. there is a STS score, frailty score, and there is no associated involvement. If the STS score is another downloadable app, you will see that operative risk is low, surgery is better. Operative risk is high and frailty is more, and the patient has two organ system involvement, possibly old CVA, pulmonary disease, peripheral vascular disease, and abdominal any malignancies where the survival is more very less, then TAVR is better. So the surgeon sees all this and prohibitively high risk, then TAVR may be better. So suppose you take 100 cases of AVR, 38% fall under low risk, intermediate risk 18%, high risk 24%, extremely high risk is 24%. So you will have at least 44% of the patient who are on high risk or very high risk. These are all the trials, started with very high risk to prohibitively high risk to intermediate risk to low risk, and then we choose the patients. So you should also know what are the complications. These are all the complications which can happen. Conduction system abnormality around 3 to 10%, and coronary occlusion. These are all the complications. So another way, this is the same thing told in a different way, which favors TAVR, which favors TAVI. And it can also be done for a bioprosthetic wall degeneration. Somebody has a bioprosthetic wall restenosis. If it is repeat surgery is high risk. And so multidisciplinary approach, you have a cardiologist, surgeon, interventionalist, all of them will come together and say that this is a low risk, this is a high risk, and we do need a CT scan, echo, lab, ECG, examination, STS score, assessment of independent living, patient is able to survive after a procedure with a meaningful life, all that is necessary. So 20 years of TAVR has gone a great revolution, it has crossed the surgical numbers. So TAVR is going to say, and this is the different ESC and ACC guidelines, contraindications we have already discussed, and side effects. These are the two valves which are available. One is a self-expanding valve, another is a balloon expandable valve, and these are all the various things. Thank you.
Thank you, sir. Wonderful. In fact, presence of aortic valve disease not just requires surgical intervention anymore. It is becoming a part of interventional strategy in the structural heart disease program. The question is whether you have a heart team approach or you have an individual approach. Has to be decided according to the availability of the